Third Rock Ultrasound. Since 1998, Third Rock Ultrasound has presented educational programs to help clinicians integrate ultrasound technology into their patient care. With thousands of courses teaching thousands of healthcare professionals at worldwide locations. This is Module 5A, Abdominal Aortic Pathology.
Hey, Pat.
Yeah.
What are we going to talk about next?
Let's talk about pathology.
What kind of pathology?
Let's talk about aortic pathology.
Aortas are, that's probably pretty good because most people have an aorta, right?
Yeah, they hope so.
Okay.
Most of them hope so.
All right, so if you're going to tell a beginner about using ultrasound to look at aortic pathology in the abdomen, I mean, what would be the first couple things you would tell them about it?
Well, I would tell them, first off, it's quick, and it's easy, and it's accurate. And that's probably three things, so I might have gone one too many.
You went too many, but still, it's a very, very important lecture, and this is a great use of ultrasound for your patients, and you can start using this very, very soon after seeing this lecture.
The objectives for this module are the technical considerations, anatomy, and sonographic findings associated with abdominal aortic aneurysms and abdominal aortic dissection. Abdominal aortic aneurysm has an increasing incidence in our aging population. In patients over 65, as many as 1 in 20 will have this disease. Risk factors for abdominal aortic disease include male gender, advanced age, hypertension, smoking, a history of vascular disease, and a family history of aortic disease. There are several diagnostic imaging studies available to facilitate the diagnosis. Historically, angiography was considered the gold standard for the imaging of abdominal aortic aneurysms. However, there are many problems with using this modality, including that it visualizes only the lumen of the aorta, it underestimates the size of the abdominal aortic aneurysm, it is invasive, and it gives a dye load to the patient when renal failure is a significant risk of treatment. Finally, it's time-consuming since the patient must be transported to an invasive radiology suite. Computed tomography also has limitations in that it is time-consuming, requires the patient to leave the emergency department, and gives a contrast dye load to the patient. Ultrasound is the best test for the rapid detection of abdominal aortic aneurysm, and images can be generated at the bedside within minutes. In addition, the test is very sensitive for detecting aortic aneurysmal disease. The limitations of ultrasound are that it has poor ability for detecting retroperitoneal bleeding, is inferior to CT for judging the proximal and distal extent of the aneurysm, creates a tendency for novice sonographers to underestimate the aortic diameter, and also that bowel gas can block the view in some patients. The size criteria for the diagnosis of abdominal aortic aneurysm uses the following two parameters. If the diameter of the abdominal aorta is greater than 30 millimeters, or if the diameter of the abdominal aorta is 1.5 times greater than the proximal uninvolved segment. Here is an example. If the proximal abdominal aorta measures 12 millimeters and the distal aorta measures 25 millimeters, then the distal aorta is greater than 1.5 times the proximal aorta and the patient has an abdominal aortic aneurysm. Always remember that the larger the abdominal aortic aneurysm, the faster it expands over time. In addition, the larger the abdominal aortic aneurysm, the higher the risk of rupture. The majority of aneurysms involve the distal segment at or near the bifurcation of the common iliac arteries. Approximately 1 in 3 aneurysms involve both the distal and proximal abdominal aorta. If this is the case, the examiner should be very suspicious that the aneurysm extends into the thorax. There are two types or shapes of abdominal aortic aneurysms. The most common by far is the fusiform type. This type of abdominal aortic aneurysm usually tapers at both the proximal and distal extent of the aneurysm. The aneurysmal sac usually projects anteriorly and to the left. There's usually an intraluminal plaque on the left anterior wall. This image displays a longitudinal view of a fusiform abdominal aortic aneurysm. A large intraluminal plaque is seen on the anterior wall. The lumen is considerably smaller in diameter than the entire aneurysm. Here is another longitudinal view of a fusiform type abdominal aortic aneurysm. Again, the intraluminal plaque is on the anterior wall, and the lumen is more posterior in location. This is a transverse view of a fusiform abdominal aortic aneurysm. Now we can see the intraluminal plaque located anterior and mostly to the left. Again, note how small the actual patent lumen is relative to the size of the entire aneurysm. This video demonstrates a longitudinal view of a fusiform abdominal aortic aneurysm. It is a large aneurysm measuring approximately 7 to 8 centimeters in size. This is a transverse view of the aneurysm from the previous video. You can easily see the lumbar spine posterior to the aneurysm. When Doppler color flow is applied, typically a turbulent blood flow pattern is visualized. The second type of abdominal aortic aneurysm is a saccular aneurysm. This type is much less common, making up around 1% of all abdominal aortic aneurysms. This type of aneurysm is formed by a bleb that expands out from the functional lumen and remains attached by a channel. Plaque and/or thrombus can partially or completely fill the aneurysmal sac. Here is a fantastic video showing a longitudinal view of a saccular abdominal aneurysm. This video shows a longitudinal view of a saccular abdominal aortic aneurysm. Here you can see the aorta proximal to the aneurysm. This is the aorta distal to the aneurysm. When color flow is applied, you can see blood flow within the saccular aneurysm. This can often be important if you are having trouble deciding if this is a vascular structure or a non-vascular cystic lesion. This is a fantastic longitudinal view of a saccular aneurysm. The anterior aspect of the sac is filled with plaque. This is the same aneurysm as the previous video, but now we are looking at it in the transverse plane. When measuring the abdominal aorta to determine the presence and extent of an aneurysm, it is important to recall that the measurement must be from one outside wall of the aneurysm to the other outside wall. This is a common pitfall for novices who only measure the internal lumen because it's easier to see. When in doubt, make liberal measurements initially and then confirm with a more definitive study such as CT. Another important pointer regarding the measurement of the abdominal aorta is to always measure the structure in the transverse or axial plane. In this example, we see that the size of the abdominal aortic aneurysm in the transverse plane is 7 centimeters. When measuring in the longitudinal or sagittal plane, the examiner may be unaware that the beam is not directly striking the target in the anterior-posterior plane. Instead, the ultrasound signal can be directed tangential to this plane and generate a falsely low measurement. In this figure, we see how measuring the abdominal aortic aneurysm in the longitudinal plane may be accurate if the ultrasound signal is at the center of the aneurysm. But if the signal is not directly centered, or if angled away from the anterior-posterior plane, it will create a falsely low measurement. So what is the utility of viewing the abdominal aorta in the longitudinal plane? First of all, it will allow you to locate saccular aneurysms that may not be in the plane of the ultrasound signal when scanning only in the transverse plane. It will also allow you to identify the proximal and distal extent of abdominal aortic aneurysms, and finally, it will allow you to look for evidence of abdominal aortic dissection.